said, hot dog. So we daringly tried it, and it was shocking how some of these severe OCD patients got better within days of giving them azithromycin. So after that, I was completely hooked. I was an adult. You have to train in adult psychiatry before you do child psychiatry, and I wanted to get closer to the source to try to nip things in the bud as much as possible. So rather than treating downstream OCD, if you can treat it right at the start, I couldn't resist hoping that we can get somewhere, and I do think we're getting somewhere well. Let's see. It's an exciting time all around in psychiatry. It would have been fun to give you this talk about all the different disorders and all the immune research that's going on, but it's really exciting. When I started training, there was a debate about, should you give people antidepressants because you might deprive them of the opportunity to get insight into why they were depressed. They were just coming out. And it's been a thrill of a career to watch. We've been treating them with psychiatric medicines, and now, since like half the people who have OCD get about halfway better with our medicine, people are looking further. And so in mood disorders, schizophrenia, autism, sleep disorders, eating disorders, OCD, of course, tic disorders, ADHD, and memory problems, people are working like mad to find out what are the immune mechanisms that can be contributing to this. Now, oops, that wasn't the right one. So just a little tiny sample, a big sample actually, 1 million Danish children were looked at, and this is looking at what's the relationship between having infection and having some sort of psychiatric disorder. They looked at the whole population. They keep records of everything on all of the children in Denmark. They looked into, did these children have any kind of mental health problem? And they found that the more you had strep infection, and no one here is probably surprised, the more likely risk ratio, it's not causal, but they were more likely to have OCD and tic disorders. That was with strep throat, but any kind of throat, sore throat also made them more at risk for having OCD and tics. I missed one, I think. Well. So this is a slide I put on to talk about a two-hit trouble. So we think in the yellow part that just talked about infection, maybe makes people more likely to get some sort of psychiatric illness, but not everybody gets it. Sue said, sorry, I'll just call you Sue if you don't mind, that everybody gets strep. So it's not just the infection. You have to have a certain immune makeup, a certain probably genetic makeup, and maybe a certain strep. If you have those, you could get inflammation. Does something to the brain that people are researching now. And one thing that can happen would be PANS and PANDAS. Dr. Sweeto also talked about the basal ganglia, which is a gatekeeper. So a simplistic way I think about it is the part that's lighted up would be, or the pinker part, is part of the basal ganglia. That it's a relay station. Things go up, things go down. And its job is to be a good filter, be a gatekeeper, and keep things from popping up like movements, like a tick. So if there's something wrong with that gatekeeper, you might get tics or moods and emotions, scary thoughts. Procedural learning, that means if you were going to walk in the snow and write your signature, it would look like you wrote it on, if you tried, on a piece of paper. These are just learned things. When you put on your seatbelt and start the car, these are procedural learning. So the handwriting can be a problem. And cognition. We see cognitive problems in people with basal ganglia inflammation. So depending on who's involved in it, you might go to different kind of practitioners with these problems. So primary care docs and practitioners could see kids for upper respiratory infections, but people might also bring their children in if they had tics, other troubles with their motor. If they started having bedwetting or accidents, they'd probably go to the pediatrician first, or if they had pain. But they might go to see a psychotherapist or a psychiatrist if they had obsessions, compulsions, anxiety, moodiness, rage. And the middle part, they could end up at anybody's office. So this is a clip from a CME video, CME activity, a free one, about PANS. But I put it in here because people are going to different practitioners. It's like the story of the wise men and the elephant. I don't know if you remember that, but one guy's reaching up. He says, "Oh, they're blind. This is a rope." Another guy says, "Oh, this is some sort of hose. Oh, this is a tree." Everybody looking from their own point of view. If they didn't know about elephants, they might not understand it's an elephant. Something that I actually think comets personally seem to take a long time to get here, but I put this into something to be very characteristic. Almost nothing starts, bam, in a day or two. First they were fine, then they're really not fine at all. Bang, I lost my child. And suddenly, you would get all these changes, well, especially OCD or food restriction, and some of the symptoms on this constellation, it would be PANS. In PANS, you don't have to know what caused it in terms of any kind of trigger. But if you are seeing somebody in any kind of office, when suddenly they really change, they have OCD or are not eating, then it's really good to think about, do they have PANS? This is a slide I just like, so I put it in. It doesn't really fit. It fits a little bit. This is a huge population study that looked at when do people start gaining OCD and who are they. They used to think or say that there were two peaks. One would be a younger peak, mostly boys, and one would be a later peak, mostly girls, with comorbid, also having anxiety and depression. But they put even more people into the mix, into the big data analyzer, and they found a very early peak. And those people were boys predominantly with OCD, tics, ADHD. So it's fun to have big data showing. There are a number of inflammatory brain disorders, and it's not really this talk's place to go over what they all are, and it's not my expertise either. But I put this in to say a number of things can cause inflammation in the brain, and some of these have prominent psychiatric symptoms. It's good to just keep that in one's mind. Everything is not PANS. And don't read this unless you're a really fast reader. The point of it is that on the left, the left column shows that different kind of inflammatory brain problems are thought to have different parts of the immune system involved. And we're still trying to figure it out with PANS, and it doesn't have to be just one part. It's a delicate balance. When one part of the immune system's out of balance, the other part has to move in, and depending how you measure it and what you decide to look at, you'll find out. And I can't wait to find out more about PANS. But what makes you think about, is it PANS or not PANS? Well, the course. I just said, and you know, that PANS comes on, bang, suddenly, by definition. And it can reoccur. Some problems are having a slow ramp up, and that wouldn't be PANS. Some of these encephalopathies have headaches, prominent seizures, focal neurological findings mean there's one part or two parts, or of the neurological exam is abnormal. They could have autonomic instability, dramatic, meaning their blood pressure and their pulse rates are all over the place. They can be delirious. They could be kind of sedate or stuporous. They could have prominent memory problems, prominent cognitive problems, and psychosis, like frank delusions and hallucinations that are prominent. You would see abnormal EEG findings in some of these, or MRI findings, or lab findings. So the answer to that is try to rally a diagnostics team. If you're unsure about what the trouble is, and it's reasonable to be skeptical and get the right diagnosis, I think the primary care professionals and the psychiatrists and the specialists, especially if you can find them, who are open-minded, to take a look and help you decide what's the symptom presentation and what's the lab that ought to be ordered. So I'm trying to answer the questions that Melissa posed me. How do things work at Stanford Clinic? Well, it's been a wonderful, exciting experience. Started out pretty much volunteering. There was no clinic, but where I work, if you just say you're a clinic, then you're pretty much a clinic. So that was good. But over time, and over politicking by my colleague and leader, Jennifer Frankovich, a rheumatologist, we got more and more permission to get more and more personnel. So now we have a pediatrician, a rheumatologist, like 1-point-something psychiatrist. We have a full-time social worker. We have an administrator full-time. So we're a real clinic, and we see patients 5 days a week, most of the day. And we have 2 rooms filled, 2 or 3, maybe 4 if you count the social worker. So we're a busy clinic, which is wonderful. And it's so fantastic to work in a multidisciplinary clinic. I have another practice, and of course I have had in my life, where I see patients psychiatrically. And when it comes to trying to talk to other doctors, when and how to do, asynchronous communication is the best, but sometimes you really would like to have a conversation, and trying to engineer that is difficult, and sadly, where I work, it doesn't get paid for generally, so it's harder to like when you're not working for yourself, to get your productivity hours, et cetera. But when you're sitting in the office with another practitioner from the other discipline, it's fantastic. We can get out of our silos. We can be as a team. You just talk right then and there. And isolation and morale are improved. So when we see patients, we always try to have 2 clinicians in the room, a psychiatrist and one of the primary care docs. Because this is a medical illness that symptoms are predominantly psychiatric. And the way we track whether someone's getting better or worse is to assess their psychiatric symptoms predominantly. But that's not necessarily the expertise of every pediatrician. So it depends on their interest. And psychiatrists are generally not in the habit of looking in people's ears and swabbing people's throats. So having us together, we can get a more complete picture. And every morning for about 45 minutes, we're on a conference call. And the whole team, all 7 or 8 of us, and we talk about the patients coming up for the day, any updates, any ideas, what direction are we going, and the patients from yesterday if there were issues, patients overnight. So it's very collaborative, and it's just a uniquely wonderful, in my experience, way to work. I want to talk about evaluation. So this is kind of a bad thing about our clinic. Despite that we're so big comparatively, we can not handle the number of patients that come. So we had to figure out how to make it workable. We are dedicated to trying to advance the research because people have told their very convincing stories. Sue has presented to you really good research, but still there are people who think it's a belief system. So we only take people who can qualify to be in our research. And that's our number one goal. Because people need to come in, and we've had such experience, there's a big tree fell down on Highway 17, sorry we can't come in for the third time, or, I shouldn't complain in front of you, but because you are more widespread, but we only take people who will really come in when we want them to come in. And we found that geographically, that's been a helpful way to do it. And because people started moving to town into those counties that from which we took patients, we said they had to be established with a pediatrician for some time. One year we turned away 1,000 people. It's heartbreaking. But the way we can live with it is, if we can figure out the best way to treat it, the way to convince other people who are skeptical, then we won't have to be the only ones in town. And we're not. The pediatricians we've been working with in our area are getting more and more on board. Here's what we do for an intake. The pediatrician will call. We have a screening checklist. This is pretty much the diagnostic criteria. Sometimes they'll call back to try to clarify something. And as they get accepted, we really try to get all their records. Now, more these days, they're electronic. But we try to collate them into a history because there's an OT note about clumsiness. There's a pediatric note about a sore throat. There might be a school note about is really in trouble at school, had to be sent home. So we try to make the timeline go together because we think that's informative. If parents can work on this, it would be very helpful because it's a very time-consuming project, and luckily we have some volunteers who, HIPAA trained, do it, but I think it's very, very important. So if you happen to be a parent and you can try to at least get the records, but even write the story, that would be, I think, helpful to your clinicians. So we do a 2-hour intake. We look through this chart review, which often is pretty long, and we ask questions both about the patients and their families. We ask, is anyone sick now? How about recently? How about in the past? Are there recurrent strep infections? Has everyone in your family had their tonsils out? That might be a clue of something. Have your grandparents or anybody else needed a heart valve replacement? Looking back to see if anyone had rheumatic fever. Do they have arthritis or other autoimmune, autoinflammatory conditions? Have they been traveling? Has anything icky bitten them? So we try to review things for sure that kind of contribute to whether or not they fit the diagnosis and what clues we can gain. Well, this is kind of gruesome, but possibly. But it's about our physical exam, and sorry, I'm not seeing exactly what you see. We ask about a rash, a sandpapery red rash, usually on the trunk. That's called a scarlatina form rash, and if you get it, it's often associated with strep. Erythema marginatum would be the upper right, which is hard to see, sorry. What we look for, that kind of rash. We look for something called livedo reticularis, which is nonspecific too. It's the forearm there. It looks kind of a lacy pattern, and people have it more often when they have inflammation. That's a sore bottom. We also ask about, and of course we don't routinely, but if there's any trouble getting resolution, or the child has been itching their bottom, we certainly would examine them there. We look for a strawberry tongue. Looks kind of like a strawberry with all the little dots on it. We look to see if their ears are red inside, and we look for any kind of joint trouble. With the erythema marginatum, which is a rheumatic fever symptom, if they take a bath, then you can see it better. If they get warm, you can see it better. In our patients, we often see them having red around their nails, and that's not just from biting at them. If you look at the roof of their mouths, they often have what are called petechiae, these little red spots. Well, I don't know what it means, but Terry lines are kind of a dark band at the end of your fingernails. It's not specific either, but we're trying to note it and see, is it just one other way we can see if there's inflammation. Dr. Sweeto talked about the neurological exam, and I will too. You saw great examples of chorea. Truncal hypotonia would be this. They pretty much stand up, okay, or they're sitting on the exam table and get exhausted because it's really hard for me too to stand up straight. I thought it was my character, but I think it's truncal hypotonia. But your basal ganglia sends messages to your muscles, say, engage. You could have a gymnast who's very strong, but they're going to be sitting like this if they have PANS. They might. They have they can have an abnormal glabellar reflex, meaning you say, don't blink your eyes, and you tap them here, and they might blink. And that's not normal if you're over 6 or so. You saw the tongue example by Dr. Sweeto, and milkmaid grip. You say, come on, squeeze, squeeze, squeeze as hard as you can't hurt me. No, squeeze, no, squeeze. And they can't sustain this strong movement. You saw the piano playing fingers. We can get ask for a handwriting sample. And the overflow dystonia, we most easily see it if you ask someone to walk on the sides of their feet, and they will walk on the ends of their hands too. It's just overflow that you should outgrow. And if you see it in an older child, then it's something abnormal. Sydenham chorea, just to echo what Dr. Sweeto said, has a lot of neuropsychiatric symptom overlap. So you can find the Big Dipper in there, but there are a few other differences. And you have to look for it because it can have heart problems. And if you miss them, the person could have heart damage. So be curious about whether you can find chorea, milkmaid grip, or their darting tongue. Or hear a murmur. If you do suspect that they have heart involvement, you can an echocardiogram, an EKG, and refer to the cardiologist. So another question I was asked to talk about was what testing is helpful and what are some limitations to testing? Well, number 1, 2, and 3, we don't have a marker. So it's harder to get credibility. We don't have a single solitary marker. People have come in and told their doctors and told everybody, and I understand why. We tested for pandas, and they don't have it because their ASO or anti-DNase B titers were negative. That's not a test. I guess Mark will talk about that. But one test never is. 2 tests might help you know if there was strep, but that's not a marker. And we have drawn lots and lots of tubes of blood on our patients, and we haven't found a uniform marker. There's no blood test that everybody has. There are some we're finding are a little more predominant, but it's a quest to find it. The diagnosis is made on the constellation of symptoms and the sudden presentation. Different patients have different symptoms to track. Some people would be their OCD, some people would be their food restriction. And some different patients have different labs to track. And I'll just show you a couple examples. Our typical laboratory evaluation, you decide largely based on what symptoms they come with. What would you have done otherwise? Plus, you look a little harder for things that you worry about in terms of infection and inflammation in terms of bigger studies like MRI. But of course, we look for strep. And many times we have found that we've checked the child, we've checked the family, and then, oh, the babysitter, or the tutor, or someone in the carpool has strep. So it's good to be curious about that. We're looking at brain MRIs, and we think we may be finding some signs of vasculitis, inflammation of blood vessels, but generally, on a regular old MRI, you wouldn't see anything abnormal. EEG, as Dr. Sweeto said, nonspecific findings. Sleep studies have been one of the most robust findings in terms of having abnormalities. And here's what we come up with. Throat culture. You might you might verify an infection, but you might not. Might be too late. Maybe you couldn't go in the back of the tonsil, right? Maybe you didn't think to culture it perianal, and if you do order that, you should specify what you're looking for, strep. In our CBCs, complete blood counts, we see more monocytes than the average person, but that's nonspecific. We see some other blood disorders or signs of it, but that's not specific. Urinalyses should be normal. If they're not, keep looking. You want to not miss some sort of nephritis, kidney inflammation. Neuropsych testing. Now, I want to say neuropsych testing generally takes hours or days, depending on the child and how they're doing. We're piloting a short, quick one, we'll see. But once you get it, these kids often have slowed processing, calculation difficulties, memory issues, concentration I didn't put in there, and motor issues. We do put the pegboard in the pegboard as fast as you can, or copy these drawings, and they have more trouble than you'd expect. What assessment tools and forms do you use? Well, that's kind of hard to, I have one strong feeling about one of them, or maybe a few. But the diagnosis is really made on history. But if you want to track progress, you can do that. This is the one I feel strongly about. This is the symptom checklist for the Children's Yale-Brown Obsessive Compulsive Scale. Anything I'm going to show here is in the public domain, meaning it's free if you can search it on the internet. So I have found treating OCD for a long time, if I don't ask, I won't find out. People will say, yeah, washing hands. Anything else? No. Well, but if I go down this list, and sometimes with a child alone, sometimes together, sometimes a parent wants to talk alone. If you ask specifically all these questions, and I don't know how much time I have, I would love to talk a lot about it, but I'm not going to. Well, I think you need to touch these things. I think you have to find out, are you worried about germs? Well, maybe it's not germs. Maybe it's like the essence of that person in the class who you don't like. Maybe it's toxins. Maybe it's other residues, sticky things, like the smell on the hand of your child. People worry, and they likely won't volunteer this. They worry they might do something terrible and hurt somebody, and they can't trust themselves. They might do unspeakable things. They worry, but these are not people who ever do that. But you have to ask, generally. They might hurt themselves, they might hurt somebody else, or they have to do rituals to keep people safe. Like one girl I treated years ago, when her dad would travel on a trip, would have to always try to orient herself in that direction to keep him safe. I mean, this is very magical thinking and very hard to do, but it's worth asking about. People can have horrible images coming into their head, and sometimes they're about suicide. And that's an interesting conversation and not always easy to pull apart. Are you having suicidal thoughts? Yes. Are you feeling like you'd like to commit suicide? No. It's horrific, but they keep seeing these horrible images. So that's something worth trying to keep in mind when someone says, when you ask the question, that you'll ask about suicidal thoughts. Also, people generally don't volunteer if they have sexual obsessions, so it's a good thing to ask, do you have trouble with thoughts coming in your mind that feel inappropriate about you doing something sexual, someone doing sexual to you, having done something sexual, about whether they're homosexual or not, they get tied up. They can worry about losing their things, so that, like, their toys have to stay in the package. They don't want to get them scratched, or they can't throw their baby clothes away even if they're torn and stained, for example. They might have unlucky and lucky numbers, clothes, words, colors. That might worry a lot about their body, kind of like a body dysmorphic disorder problem. They might worry a lot about, did they do something moral or immoral, something right or wrong, something that's a sin or not. So it's really important to, I think, be curious about this if you're looking for OCD. We've only had one case. Well, they have to really get screamed to see us, but I couldn't find it. There was a boy, well, I couldn't, might have been there because everything else was there, but it was mostly separation anxiety. I think I just didn't know what the worry was about why it would be so bad and the child couldn't volunteer it. If you want to quantify tics, there are scales. This is one that's detailed. It asks about what kind of tics people have, specifically, in detail, how many they have, how frequent they are, how intense they are, like mild or like really intense, how much it gets in the way. And you can come out with a number and also a record of how things have gone. This is an avoidant restrictive food intake disorder scale. Also, a real scale would probably be good. But it's kind of like the SciBox test, and I think if you're researching it or looking at it, this one we added the modified overt aggression scale, and we find that kids are, when they're 1 or 0, they're typically not flaring. But when they're flaring, we see it really increase. Well, it's kind of self-explanatory. Are they aggressive to themselves? Are they aggressive to other people? Are they yelling, screaming, cursing? That's pretty easy to fill out for the parents, but it is another thing that we think tracks well. But the very best thing that is tracked with our severity of illness is called the caregiver burden. And it looks at how much has this affected the parents? How much is it making their lives different? What's their time like? Do they have any time? What does the parent get to do? Do they get to see friends, take a class? Do they wish they could run away? Well, how's their health? Generally, I've seen parents really let their own health go because they have another job. And of course, the emotional strain is tremendous. So we find that in a flare, understandably, this is really high, and it can improve with time and treatment. Okay, this is There's a little bit of a joke on the right, but it's not a joke. We are doing research. So we have the PANS questionnaire. This is the first one you take before you come. 102 pages. Luckily, it's computerized, so I'm not recommending that necessarily. But on the other column, it's a bit of it, and it's an important part of it. People are working to try to see is what kind of valid, reliable measure they can derive out of this. So here's something someone has invented, is a Pandas PANS journal. I'm not trying to sell it, but it's an app that's available. And it has a lot of, makes a lot of sense to me. You can put in what symptoms are like, what was the intervention, did we start antibiotics that day, things like that. Because who remembers what they did 4 days ago and how they felt? I mean, it's not easy, or how their child felt. So this kind of thing, you can get more objective data. So I got a little grant to, oh, nuts. Well, if you just search it, you can find it, although it's not a good interface in my mind. It's hard to find, but you can find it. Anyone can do it. It will say what's your license number for if you're a licensed healthcare provider, but you don't have to have that, and you can ask your doctor to go take it. But it's like an hour or something, and you get CME, continuing medical education credit. So just wanted you to have that as a resource in addition to the Pandas physician network. So that's what I wanted to say for this part, but I'll go on. So we have seen something like 300 patients, and I'll tell you some things about what we've seen, and I'll probably tell you some things later. We find our mean age of onset is 8.8, mostly boys, and it's taken them a couple years to get to clinic, which is really upsetting. Glad they're there, but, and this is who we see in terms of the disease course. We are really thinking, based on the early results from our research, that there are different processes happening early in the illness, like burst onset, and then later when you have relapsing, and then people have chronic kind of static, meaning it's not really changing much. They kind of seem to be stuck. Although we've also treated people who have had that with improvement. Mostly, we've had relapsing remitting, which is classic, with the sawtooth pattern, getting worse, resolving, getting worse, resolving, getting worse, resolving with different infections. We'd like to get everybody in right away and have them treated right away and see if we can get that single episode number quicker. And of course, that's our project here for everybody. This is pretty much what's same as Sue said. It seems like the problems on the diagnostic criteria seem good. We do see a lot of them in the patients in terms of psychiatric symptoms. We did a chart review, which is a tedious but interesting process, and we're curious what does this mean, psychotic symptoms in kids with PANS? Because when people generally think of someone psychotic, they think of them really have lost touch with reality, kind of enduring, and that's not really what we found. We found a third of our kids had hallucinations, same amount, about a third had visual, a third had auditory, some people had both, but they were really pretty much transient. They just came and went. Like, did you see that man over there who was in that manhole, but now he's gone, kind of thing? Or I thought I heard some bells or clicks, but then they're gone. The minority had delusions or thought disorganization, and that was only a few patients, and maybe we have to look back at their diagnosis and see if something additionally going on. But the people who did have psychotic symptoms, it seemed like they were having a harder course of illness. A lot of people, 2/3, had urinary changes. Almost everybody had trouble with sleeping, trouble falling asleep, nightmares, restless sleep. Reverse cycling means they go to bed at 2, 3, 4 in the morning. And then the REM motor disinhibition that we saw so dramatically in your presentation. A lot of people. Now, we have a rheumatologist in our midst, and it's very interesting that we have seen a lot of arthritis. Often, we don't find out in the storm when all the psychiatric symptoms are prominent, because it's not what people are thinking about, talking about. But it becomes more evident in terms of history and physical later in the course. And enthesitis is pain where the attachments are, where your tissue attaches to bone. It's like a lot like trigger points, myofascial points for fibromyalgia. Spondyloarthritis, these people, you'll see they wake up stiff in the morning, and their feet can hurt, their backs hurt, their neck hurts, and they have to keep moving during the day when they're sitting to try to get comfortable. The more they move, the better they feel. Some kids have had transient or reactive arthritis, and we're seeing some kids with psoriatic arthritis, which goes along with psoriasis. This is much bigger than the general population. Pain amplification means we've looked carefully, we don't see any reason physiologically, physically, for your pain that's like a broken bone or prominent inflammation, but yet we believe you that you have a lot of pain. Half of our kids had that. It seems to be most around the time of onset. They also get stomach aches and headaches. And the more time went by, this is called a decay curve, where your chances of having no pain went down as time went on. Especially, we don't know yet about treatment. It's early in terms of, even though we're working hard to catalog all the data, the 102 pages that all is entered right into the computer, we're getting blood samples, we're trying to figure it out. Fatigue symptoms are prominent too. These kids wake up unrefreshed and feel tired during the day, a lot of them. Some have exercise intolerance. We've talked about REM motor disinhibition. We look at 9 patients who had chronic PANS. They had had it for at least 4 years. And they had this trouble moving, working, living out your dreams. You're supposed to be paralyzed, but just, well, I've never seen a more dramatic film of it. They were also less efficient in their sleep. So there's definitely some sort of signature, it seems, for PANS, at least many people with PANS and their sleep disorder. I showed you those pictures of things on the physical exam, the Terry's lines and the redness around the nails. We saw in roughly half. A quarter had that livido, that lacy pattern. 44% had those dots, red dots on their palates. We also have some markers in some people, but this is such a smattering. These markers happen to be markers looking like you have vascular trouble, blood vessel trouble. We've had some patients, a few, with immune deficiency, and if you have immune deficiency, you're not, at least what I'm talking about, they're not making enough immunoglobulins. They had lots of sinus infections, our patients, and replacement IVIG was really helpful. There was much more than the general population in terms of autoimmune problems. This is in the patients, autoimmune thyroiditis, celiac disease, chronic hives, urticaria, antiphospholipid syndrome a tiny bit, type 1 diabetes. One of our patients developed it while under our care. And over time, it seems like these autoimmune troubles seem to manifest. You see them developing. There's a higher chance over time that this will happen. I don't know why, and I don't know to whom. But I think it's worth looking at, especially if you worry about someone's thyroid, symptoms of hypothyroidism, hyperthyroidism. As I said, we try to get blood drawn when they come, when they're in a flare, and when they're in remission. Dr. Frankovich has managed this blood biorepository, and scientists all over our university and elsewhere get tiny little aliquots for their studies. But she's masterful at reaching out and trying to get people interested. It's an interesting disease for scientists to study because it's not like you have to wait for someone, it's worthy research to get Alzheimer's over time. It happens, stops, happens, stops. So maybe there's more of a chance to capture the etiology. HLA is what they check if you're going to get a transplant. You want to have matching HLA. And it's like a two-step authentication for you to try to get your immune system going to fight infection. We found that we have orange really sticking out, some differences than the general population. This was compared to people, families, who had come into the hospital trying to get typed because their relative was going to get some sort of transplant. But those are really, really significant findings that certain people with certain genetics really stood out in our population as more likely to get PANS or PANDAS. And you see it run in families, as you've heard and you know. Looking for a marker, these are the typical, some autoimmune markers. As you can see, the minority of people have them. The minority of people, but some people have trouble with making their blood cells or their platelets. These are other inflammatory markers. You can see this elevated C4A. There's something called the complement cascade. It gets activated with infection, and it's a miracle. Well, most things are if you really look at it, but it keeps chopping off different parts that have of this big thing that have different jobs. And in inflammation and vasculitis, you can find an elevated complement 4A component, and 69% feels kind of high compared to some of these other numbers. And we found that the people who had higher complement levels had worse problems. So that is what I wanted to say about making the diagnosis. I hope it has helped with your questions. Let's see. Thank you.